Welcome, everyone. We're glad you were able to make time today to join us for this webinar on telemedicine and dystonia. I am Janet Heischetter, and I serve as the Executive Director for the Dystonia Medical Research Foundation. It's my pleasure to welcome you. Before we get started, allow me just to make a few announcements about the webinar today. The audio for the webinar is available via phone or through your computer speakers. Due to the large number of participants today, everyone except for the speakers will have their lines automatically muted in order just to keep the background noise to a minimum. If you're using your telephone, please make sure that the phone call button on the audio pane of your attendee control panel is selected. And you will also need to enter the audio pin that is shown in that audio pane and remember to turn your computer volume off. If you're listening via your computer's speakers, please be sure to select computer audio button in the audio pane of your attendee control panel. Your questions are an important part of this program today, so please write them down in the question pane as you think of them, and we will do our best to get to all of them today. If you have any technical difficulties at all during the program, please feel free to reach out to Jody Roosevelt, who is a master at helping people with their technical challenges over the phone, and Jody will do her best to try to help you so that you can fully benefit from this program. It is being recorded, so should you have any problems, you'll be able to hear it online at some point in the future. So now on to our program. I am just so pleased to be joined today by Dr. Harini Sarva, a movement disorder neurologist in New York City at Weill Cornell Medicine. Dr. Sarva received her undergraduate degree in economics, graduating magna cum laude from SUNY Brooklyn College, and her medical degree from SUNY Downstate Medical Center. She did her residency in neurology at SUNY Downstate and later became the chief resident. Dr. Sarva did her fellowship at Mount Sinai Beth Israel with Dr. Susan Brusman and Dr. Rachel Saunders Pullman as her mentors there. I'm also very pleased to say that Dr. Sarva is a former DMRF clinical fellow. She's been very active in the foundation, speaking at educational meetings, reviewing education materials, and she is now the founding chair of the DMRF Clinical Education Resources Committee, helping us to strengthen our patient educational materials and looking at all of our materials from a clinical perspective. We're so grateful to Dr. Sarva for all the work she does in support of the dystonia community, and just really pleased to have her here today to talk about telemedicine. So let's get started. Dr. Sarva, welcome, and thank you for making the time. We are looking forward to the conversation we're going to have about this new method of providing medical services to the dystonia community. Are there general comments that you'd like to make about telemedicine and just in the time that you've been actively involved in working with your patients through telemedicine?
Well, first of all, thank you, Janet. Thank you to the DMRF for this wonderful opportunity. Good afternoon, everyone. Yeah, I mean, to put things in sort of a historical perspective, you know, the stroke people really sort of set the tone for telemedicine about over a decade ago and have allowed greater access to a large number of patients who have suffered from acute stroke. Since that time point, there have been greater push for using telemedicine for chronic neurological diseases, with a lot of literature out focusing on Parkinson's disease and the success in treating Parkinson's using telemedicine. Due to the pandemic, we've basically been forced to use a lot of telemedicine. You know, as an more or less an old school neurologist, I really enjoy seeing my patients in the office and you know, doing the routine exam. But it's definitely a different perspective on how to take care of patients. And I think the patients have sort of evolved with the process, and so have we. And I think our styles have sort of evolved. And quite honestly, I think it's a great opportunity to be able to treat patients in their home environment. And it gives us a better snapshot as to how people are doing. And sometimes the clinic can be a little not quite consistent with what patients are reporting at home. So I think it has a great potential for really expanding access and giving us a better view of how patients are doing at home.
And I think you raise an interesting point when you said that you're learning as well. So, I think it's important for all of us to remember that our physicians, this is new technology and a new way to interact with patients in many cases as well. So we're all learning together.
Oh, absolutely. And we're also trying to utilize as many different platforms as possible. We are evolving with the technology because different platforms offer different capabilities in terms of whether it's allowing family members who are in another state to join in, or better cameras, or just more flexibility in terms of devices that can be used. And that's also allowing us to sort of expand the way we think of how we can treat our patients. And also to provide counseling for family members who may be out of state and can't always join their loved ones for their visits.
Yeah, that's a really important point. Yeah. So we received a number of questions in advance, and we're going to just put those up now. So the first one was, can my doctor really tell what's going on with me over video? What are the advantages and disadvantages of telemedicine compared to an in-office appointment?
Yeah, that's a good question. And it was even something that I kind of struggled with when I was first starting out. But the more that I do these visits, I feel fairly confident that it can mimic much of what can be done in the clinic. It starts off with taking a really good history. And there are a lot of parts of the neurological exam that, translate to video. Whether it's the mental status exam where we're asking about patients' memory and cognition, checking their eye movements. Sometimes the cameras are really good and we can actually take pictures, and if we see something, we can either contact our ophthalmology colleagues. The movement disorder exam is fairly straightforward and it's fairly well delineated, and that allows us to capture the most important parts through video. There are things that we can't do, obviously. We can't check to see if someone is stiff because we can't, put our hands on them. We can't check reflexes, but we can see them walk. We can, see them write. We can, see if they have tremor. So there's much to the neurological exam that we can do. Again, disadvantages-wise, there are parts that we can't do. We can't check reflexes. We can't check their tone. Sometimes doing a strength exam is not always feasible. But we can come up with different ways of sort of replicating maneuvers or using different maneuvers to get the same information. The other is also it's a very distant kind of way of seeing the physician too, especially for newer patients. A number of them have said, I wish we could have actually met you in person. But they were also, grateful that we were able to at least meet under these circumstances and have as long a visit as we could.
Yeah, that's important. I think I think we would all agree there's really nothing like that sort of human-to-human contact, and we all look forward to getting back to that. But this is a way for patients to still be seen and be able to work with their experts like you. So, it's good, right?
For sure.
Yeah.
And also, there are things that we could probably not be able to replicate in the office that we can at home. Particularly for dystonia, there are certain dystonias that are very task specific, and particularly if it's using specific tools or something. And while we can try to have patients do maneuvers in the office, it never quite is the same. But if the patient is at home, we can always say, okay, maybe if you have that tool that that your arm is going to be twisting in, can you grab it and show me what it does when you're using it? It can give us a different perspective on the condition.
Yeah. So our next question is this secure? We hear a lot about just things not being secure over the internet, and having a candid conversation with your physician. You want to make sure that it is secure.
Yes, it is. So there are many platforms that are secure. Many institutions use Epic as their electronic medical record, and that's certainly a secure platform. There are other platforms that are used and other medical record systems that are used by institutions that are secure. at this, there's been a lot of laxity in terms of from CMS in terms of what we can use. So we're using different platforms to get in touch with our patients. But for the most part, there is a lot of security when we are using these electronic platforms.
So the electronic platform, it's not like you're just FaceTiming with a patient. You're actually using a predetermined, very specific platform to have these interactions, correct?
It's variable from institution to institution and practice to practice. So we can use, so generally speaking, we do use our electronic medical record system that has a video capability. Weill Cornell also has a very secure Zoom platform that we also use for patients who don't have smart devices, but they have working computers. There are other HIPAA compliant platforms that, once the compliance office and, the institutions are okay with, we have been sort of branching out and using them. So whatever we feel the institution is usable for the patients, also we have to take that into consideration as well. And as long as the the institution and the practice as a whole are okay with it, we're using different platforms.
Right. So you mentioned that CMS, the Centers for Medicare and Medicaid Services, have relaxed some of the standards, I think really as a result of this pandemic, so that patients could have access to their physicians. Do you expect them to then go back at some point to a more strict kind of standard? Or going forward, do you think this is sort of where we're at? Unfair question for you because I'm asking you to guess, but...
Well, I think that, because there is such large-scale use now that hadn't been in the past, except for, dealing with acute stroke patients, hopefully it will show CMS that this is a very viable and cost-effective means of treating our patients, and that this can continue in a very productive way. And also it provides a lot of access to patients, who do have difficulties going to their care providers, whether it's because of distance or transport issues, or they don't have someone with them all the time. So I think logistically it makes a lot of sense for them to continue it. I don't know if it's going to be as lax as it is now, and I foresee probably reimbursement issues down the line, but if it shows to be an effective treatment option for patients on a large scale, which I think it will, hopefully it'll remain for the long term.
Yeah, no, that makes sense. Yeah. So this next question, we talked about a little bit, or you mentioned, not everyone has a smartphone, and if they have a computer, it can be used. So can you talk a little bit about the technology that the patients need in order to participate in telemedicine?
Generally, they need a device that has a camera and a microphone capability. So that can be a computer with a camera and a microphone to pick up voice. Smartphone, any smartphone, whether it's Android or Apple. I know a lot of my older patients have iPads so that they can FaceTime with their grandkids or see pictures of their grandkids. So any of those devices will allow patients to participate through this means. And now that a lot of devices are becoming less expensive, I think that access will definitely expand.
And is there somebody in the office that helps get ready? I mean, is there somebody who sort of talks you through the sort of steps so that you reach your physician? What's the technical support, I guess?
Yeah, that's
for the patient.
That's a really good question, and I think that's also evolved over time. For us, our secretaries do a fabulous job in basically asking the patients up front, what kind of technology do you have, and what are you comfortable using, so that we can let me or any of my colleagues know to either dial into or log into to connect with our patients. And then depending on that, they will also tell them exactly, how soon in advance they should be ready for the visit, what do they need, they need to make sure their cameras are on, which link that they need to be able to click. So, it really comes from, having a wonderful ancillary staff to kind of set that going during the appointment time. We do have some IT support, again, because of the pandemic, a lot of our tech support has been sort of redeployed to other areas. But I think, as time goes on, things are going to get easier and there will be tech support.
Right. And I think also, to one of your points earlier, I think people are starting to get used to this. It's how we're interacting with family who are, away and that kind of thing. Everybody's becoming a Zoom expert. So.
Yeah, actually, I've had a number of patients even tell me or even message me and say, do you do televisits and can we set them up?
So this next question, I think, is also something that is a good question around just the, what if my internet's not reliable? What if I'm, in an area where I just, my internet's not the fastest and that kind of thing? What kind of advice should we give people around that?
Yeah, I've had visits like that, whether it's due to like a router issue or just an internet Wi-Fi issue. Always, we can always say let's like sort of restart the visit. I always advise the patients maybe move to a different location in their home. So there are ways that we can always overcome it. If one platform is not amenable to the internet issues, I'm more or less flexible to switch to something else so that I can always continue the conversation. And if worst comes to worst, I'll just call the patient and at least we'll be able to talk about things and at least talk about our plan going forward.
Mm-hmm. Yeah. So if worst comes to worst, an old-fashioned phone call is also something that can still be helpful.
Oh, 100%.
Yeah. Yeah. So this next question is really also just, and again, maybe unfair asking you to sort of guess about sort of the field in movement disorders, but are most movement disorder clinics now moving toward telemedicine appointments? And I mean, you mentioned that one of your patients actually asked you if you could Zoom. Do you see that happening more and more?
Yeah, for sure. I speak with colleagues, around the city and other parts of the country, and they are using a lot more telemedicine to contact their patients. Of course, they are still bringing in those rare patients that either need treatment or they just need a closer evaluation. But telemedicine is definitely expanding, and most major institutions should be able to offer telemedicine, if not all of them.
And do you see this as a possibility of being able to do across state lines at some point as well?
Yeah, a lot of my follow-ups are not even in New York. So I see all of my follow-ups I can do by telemedicine. For new patients, I'm allowed to see those in Connecticut and Florida, and I also have a temporary New Jersey license. So there are states that are offering temporary licenses for physicians, so you can cross state lines.
Oh, that's good to know, I think, So how much time, generally speaking, should someone expect to have with a telemedicine appointment? Is it generally more time than you would have in the office, or is it less, or how do we prepare for that?
I would treat it just as if it was a regular office visit. So expect, if it's a new patient, 45 minutes to an hour, depending on the physician and the clinic setting. For follow-ups, again, 20 to 30 minutes, again, depending on the organizational structure for the clinic or institution. But generally, it should pretty much mimic what the in-person visit will be like. So when you're preparing for a telemedicine visit, it's to make sure that you logged in, several minutes before, that you have your list of medications with you, and to just, think of it just like a regular visit and how, to expect what a doctor would normally do in person, make you walk, check, your vitals, things like that, and to have your family member or caregiver with you to provide collateral information.
Mm-hmm. And if you're running late, is there someone in your office that sends a text or an email to the patient saying, the doctor's running late, your appointment's going to be 20 minutes later than we thought, or or should they just be waiting ready to go?
Generally, what I've done is, if I'm a couple of minutes late, I don't really do that. But if I know that it's going to be a little bit longer, I do let my secretaries know ahead of time to reach out to the patient, just let them, know that I'm running a little bit behind and when to expect me.
That's nice, because these things happen, right? People ask you different questions and you get a little delayed, and we're not always able to, right down to the minute, be able
No, of
to
course.
figure things
Yeah,
out. Yeah.
exactly. I mean, you sort of think of it like as much of a regular clinic day. You know, generally try not to run too late, but it does happen. And you know, there are times where there are, you know, family members have other questions, or there's another issue that's come up with the patient. So it's not really that set in stone. There's a little bit of fluidity to it, but more or less it flows fairly well.
Yeah. So this sort of feeds into that as well. So how, advice on how best to prepare. You mentioned a little bit to be there, have your medications there, perhaps a list of questions, that kind of thing. But is there advice to give for how to prepare for a telemedicine appointment that you wouldn't necessarily give, you know, for a regular appointment?
I think the best advice is to still consider it like a regular appointment. So show up maybe 20 minutes early, make sure that your device is plugged in and charged, the camera is working, have all the medications with you, have your list of questions, because sometimes you can't always go back to the doctor and grab them and ask them another question. And then make sure that if you need to have another person or someone else who can provide collateral information, we would probably have to know that in advance, so we can use whichever platform that will allow a third party to come in, whether it's Zoom or something else, or maybe just to have that person present. So you may have to sort of schedule it that way, and just assume that however much can be done at home will be. So if we see the patients walking, to make sure that there's enough space for that, and generally to prepare as if you would for a regular doctor's visit.
So you mentioned earlier that one of the benefits is that you actually get to see your patients in their home environment, and if there are things that they have talked to you about that trigger some of their dystonia, you can actually see that, where maybe in your office you're not able to see it. But I could also see where people who especially are not used to the technology might be more nervous, right? Just sort of anxious about wanting the technology to go right. So until they get comfortable with it, they should just prepare best, as you said, get things teed up and make sure that you're set and all of those kinds of things, right? I mean, the more you use the technology, the better you get at it and the more comfortable you are with it.
Yeah, definitely. I mean, I've had patients, log into their appointments even 30, 40 minutes ahead of time, and that's fine. It's better to be early, whether it's an in-person visit or online televisit, than late, and just to work out all the kinks. And for the most part, at least what I've experienced, is that the patients are enjoying it, because they are in their home environments. It's not a sterile clinic. They feel more relaxed. They appear more relaxed to me. And I think that we're just able to have a better conversation.
Yeah. So our next question is really about, you talked about, you utilize EPIC, the electronic medical record system. How was the record updated?
It's different from practice to practice and institution to institution. Generally speaking, we still have faxes coming in. We still have patients who email the secretaries records or things like that, or they'll email me records and I'll forward it to the secretaries to upload onto EPIC. So even though we are working remotely, a lot of the day-to-day office stuff is still working. So faxes are working, emails are working, all that stuff. So it shouldn't be that much of a problem in terms of getting medical records updated and uploaded onto the system.
And you mentioned earlier that this is a wonderful forum to bring in those family members who may not be living, in a geographically convenient place for the patient. So, are most physicians open to having, a family member on a telemedicine appointment?
Ultimately, it's the patient's decision, and if the patient wants another person there, we're happy to accommodate that. I'm happy to accommodate that. So as long as it's the patient is okay with it, then I see no problem with it.
And when they want that, do they tell that to your secretary when they're setting the appointment up? Because there may be additional technology that would have to be factored in. What's the process for that?
Yeah, either they'll tell the secretaries up front, or like I said, we have very experienced secretaries who will ask that question, and they've also evolved with sort of the situation as well. And now they're basically asking the patient, "What do you have at home, and how can I help you set that up?" So, it's been a nice evolution on multiple levels. So. Either the patient will bring that up, or the secretaries know, because we do deal with quite a number of elderly patients to ask about family members and things like that.
Yeah, that's really a nice service. I'm
Mm-hmm.
sure those family members really appreciate being able to be a part of that, because it's hard to be that long distance family member and not always know. And we all know, we've all been through that, where you don't quite hear the physician right, and you're trying to report back to your loved ones, and so to have somebody actually participate is really nice. So
yeah, definitely. I mean, I've had children and siblings and others just participate, take notes, and are able to pass that information along to the patient as well. So it does, it is a really nice service that we're able to provide through telemedicine.
yeah, so actually your comment raises another question, and that is, and I know you see mostly adults, but if children were being seen for dystonia, is there advice to the parents on how to prepare for a pediatric telemedicine appointment?
I would say similar to preparing an adult patient. Make sure that you're able to log on to the platform, that it doesn't conflict with, especially now with a lot of homeschooling and teleeducation, that it's a time where it doesn't interfere with classes and other things that the children are involved with. To have their list of medications, and maybe just like a little bit more of an open space. So, I know that when I'm seeing younger patients, I'll have them run across the hall in my office, or hop on one leg or something like that. So there's a little bit more room to examine them, because there are a little bit differences in terms of how we do examine pediatric patients compared to adults. So things like that.
Yeah, that's good advice. So our next question is really around other subspecialties. So mental health, physical therapy. Is telemedicine something that is currently being used to provide these kinds of treatment services, or something that we can look forward to in anticipating that these kinds of services might be available to the dystonia community?
Yeah, there are mental health professionals and physical therapists who are already engaged in telemedicine, and more who are transitioning towards that. Yeah, I've gotten good feedback from the people that I've sent for physical therapy. They like working with their therapist. They feel like it's helping them. There are things that obviously, you do miss out, for example, certain massage techniques, or using stimulation to kind of ease pain that, you don't get through physical therapy. But I think for the most part, there are things that definitely can be done virtually, and can be enhanced later when, practices begin to open up in a more safe manner.
Sure. We have questions now from people who are participating this afternoon. A number of questions about, people, just the way the calendar fell before cities went into shelter-in-place orders, and they were not able to get their botulinum toxin injections. And some are really, really suffering. Do you have some general advice on, what those people might do to sort of ease the pain and the discomfort of their dystonia?
Yeah, for sure. So for a number of my patients, when we went more or less into shelter in place in New York, I reached out to a number of my dystonia patients and other toxin-treated patients, and I said, "How are you doing? I can try to evaluate you and offer you some pain relief, virtually. Do you need to come in sooner? Where are you right now? If you're out of state, do you want me to give you a referral source so that in less hard-hit areas, you can get a secure and safe appointment to get your injections, and we can always transition you back when things are a little bit better here. Here are some physical therapy resources. I know that some of my migraine colleagues have been proactive in treating some of their more severe patients to prevent them from going to the emergency room. But they've also been doing it in a very safe manner, making sure that the patients have been screened ahead of time, screened at the time of the visit. They're masked, they're gloved. So there's a whole procedure. But for the most part, many of my patients have said that they just want to wait till we open in a more secure manner. But I've offered either topical pain relievers, physical therapy. Also standard, dystonia medications like benzodiazepines, baclofen, anticholinergics to help with pain. But I think the other important thing is to stay in constant communication because then you'll at least get an idea of when the practices are opening and what the procedure is when they open.
Right, and to get in that queue, right, to get your
sure.
Injections scheduled so that you
For
can start to get some relief.
Mm-hmm.
We have a question about someone. We talked a little bit about telemedicine across state lines. How about internationally? Are you able to see patients through this technology in, say, the UK?
No, well, we don't have international capability, but follow-ups anywhere in the United States and new patient, again, there are certain state restrictions, but we can go to a couple of different states.
Okay, yeah, that's and do you know is telemedicine being utilized internationally? Do you have a sense of sort of what the scene might be in the UK?
I think I was actually looking up some literature recently, and the places that have sort of a single payer healthcare system tend to have opened up and utilized telemedicine a lot faster than we have. So Canada being one of them, and other places that have like a single payer system where they don't have a lot of bureaucratic issues to impede the expansion of telemedicine. So a lot of countries are using telemedicine and quite effectively.
Mm-hmm. Well, this may be a little unfair, and I apologize in advance. But how is the billing done for telemedicine appointments? I mean, is this something that the front office, it's just billed through your insurance? Is insurance covering this?
Yes.
Do you have a sense of that?
Yeah, for the most part, it is billed through the insurance. Weill Cornell has been fortunate to have a block grant. So if there are insurances that are either denying the claims or the block grant that we have is covering it. So that gives us a little bit more flexibility. However, CMS has pretty much, allowed reasonable reimbursements for telemedicine visits on par with in-person visits. So we're basically sending it to the insurance companies and kind of taking it from there.
And are telemedicine appointments treated just as in-office visits, so that if somebody missed a visit, they may be charged for that? Do you know?
It's different per different. It's different based on different practices. So there's some practices that say that if you don't let us know in 24 hours, you will get some fee charged. We don't do that. So our usual response is to just reach out to the patient. Maybe they've had technical issues and they couldn't get in, or there was something else that sort of popped up. But we're always happy to reschedule our patients. We don't actually charge like no-show fees.
Yeah, yeah, and through a telemedicine appointment, you're able to determine, as you mentioned, some of the other medications that may be used in lieu of right now, botulinum toxin injections for those people for whom that treatment is successful. Are there? We have a question about topical treatments that may be used to help with pain. Are you aware of those? Do you know of any? Do you typically use them?
Yeah, I use topical lidocaine. Most often I use topical lidocaine when I'm prepping the patients for the day of the injection, but some patients even use them in between shots, and they say that it can help at least temporarily. You can use also topical ketorolac and anti-inflammatory creams that are also helpful. Sometimes lidocaine patches can alleviate some, muscle pain. I also recommend like a lot of warm compresses, gentle stretches. And I've had a couple of patients that I've treated with diazepam and other benzodiazepines or baclofen, and it seems to be helping at least hold symptoms until patients can get their injections.
Yeah. So this is also, again, another unfair question with so apologies, but looking forward into your crystal ball, how do you see telemedicine now sort of marrying with traditional in-office kinds of appointments? I mean, do you see telemedicine continuing? Do you see it as an opportunity to do better, more frequent follow-up with patients? How do you see it as a clinician going forward?
I think a little bit of both. Definitely it allows for greater access. So patients who don't want to travel outside, it's allowing us to still see our patients, either follow-up patients or new patients. I think that it will continue to a certain extent, even after things recover from this pandemic, whenever that may be. So it definitely has an important role in treating our patients. And I think especially for chronic neurological diseases where, mobility can be an issue, transportation can be an issue, where, so many patients may require family members to be present, it is a convenient option for them. So I think that it's going to be here to stay, hopefully for a long period of time.
Mm-hmm. What about DBS and telemedicine? Are you able to program patients, change their settings, that kind of thing?
Yeah, that's a very interesting question. So I've had a handful of DBS patients that I've done telemedicine visits with, and we've basically sort of treated it like a similar in-person visit, and I'll walk them through how to adjust their patient programmer. Obviously, if they need more extensive programming, we will schedule a slot for them to come in. The other thing that I've also been doing is putting them in touch with their reps from the DBS companies, whether it's Medtronic or Abbott or Boston Scientific, so that they can troubleshoot technologically any issues they may have with their programmer, or to retrain the family members on how to use the programmer if it's been a long time, so that they have like another source. But I think ultimately we're going to be having to bring in the patients to do in-person programming.
Mm-hmm, mm-hmm. And you mentioned that you've seen a number of new patients now utilizing telemedicine. Do are you able to make a definitive diagnosis of dystonia through a telemedicine appointment, or do you ultimately want to see a patient in the office? I mean,
So far, I've been able to diagnose my cervical dystonia patients with cervical dystonia. I think if the symptoms are really very vague or the exam isn't very clear on the camera, then yes, I will bring them in. But I think that, if I'm asking the right questions, and hopefully I am, and I'm able to see how they're moving, hopefully I will be able to pick up on the diagnosis. But there will be cases where I will bring them in so that I can examine them in much more detail.
Good to know. And then we have a question from someone, actually probably our final question. Just want to be mindful of your time today, about how they can get telemedicine. How do they know that a physician is practicing with telemedicine?
I guess simply to just ask the office when you call them. Right now we're trying to do as much telemedicine as possible, and that's probably what we're offering first, unless there's just something that we really need to see the person in the office for. So I think a lot of practices are offering telemedicine, and the secretaries, depending on the practice, will let the patient know which days the doctor is actually in the office as opposed to not. So it gives people a lot of flexibility. So the secretarial staff should be able to provide a lot of that information.
That's great. Thank you. And then I would just note that in the Dystonia Medical Research Foundation physician referral that we have online on our website, we are now going through the process of surveying all of the physicians who are listed there to ask them if they practice telemedicine, so that people who come to our site would know, and that could be a resource for them as well. So
great.
This has been great. Dr. Sarva, you're terrific, and we just feel so fortunate to have had this time with you. I appreciate your time so much. I know how busy you are, and we really appreciate you helping us to get comfortable with this new method of working with our healthcare professionals and developing treatment plans and making sure that we're well treated. So thank you so much.
Oh, thank you. This has been a wonderful experience, and I'm happy to do this.
Well, we're happy to have you anytime. So thank you, and thank you again to everyone who attended today. This webinar will be online in a couple of days as soon as we get it edited and posted. And there are other webinars online as well. One on COVID-19 and dystonia. We had a question about that. I refer you to the webinar that's posted. So again, thank you, Dr. Sarva. For all that you do for the dystonia community, and specifically for the DMRF. We're really fortunate to work with you. So thank you, everyone. Stay safe. Thank you. Bye-bye.
Thank you. Bye.